All right, so hi guys, my name's Catherine and I'm with Sophia and we're going to be doing a tutorial today on MSK. So our learning outcomes are as below. So we're going to cover kind of the main MSK presentations. That includes osteoarthritis, rheumatoid arthritis, different fractures, back pain, soft tissue injuries, and osteoporosis. So trying to cover the different things that you'll see as an F1 and an F2, but also the things that you'll see that comes up commonly in your finals as well. So this is just kind of a photograph of the MLA curriculum. So we're just showing that we're trying to tie in with that as well. All right, so as usual, it will be 10 questions of multiple choice answers. So let's get started. So question 1. A 45-year-old man presents to the emergency department with severe lower back pain that started 24 hours ago after lifting a heavy box. He also reports difficulty urinating and numbness in the perianal region. When you examine him, there is reduced anal tone and decreased sensation in the saddle area. What is the most appropriate next step in management? Cool, so we'll go ahead to the answer. So in this case, he needs an urgent MRI spine. So this question is trying to link into cauda equina syndrome. So the patient's presenting with red flags that are consistent with cauda equina syndrome. So those include severe back pain, urinary retention or incontinence, saddle anesthesia, and decreased anal tone or fecal incontinence. So in short, cauda equina syndrome is a neurosurgical emergency. So it's caused by the compression of the cauda equina nerve roots, usually due to disc prolapse, maybe after somebody's been lifting something, or it can be kind of out of the blue as well. the patients need an urgent MRI to try and confirm or rule out the diagnosis. And a delay in the diagnosis and decompression can lead to permanent neurological deficits, so things like paralysis or incontinence as well. So obviously the other things that were listed would be inappropriate because they wouldn't be the first line things. So pain relief is kind of one of the options that we would give as well whilst we're waiting for the MRI, but the MRI is the first line thing that we do. Cool, so moving on to question 2. A 62-year-old woman presents with gradually worsening pain and stiffness in her knees and hips over the last few years. The stiffness lasts less than 30 minutes in the morning and improves with movement. Examination reveals crepitus and bony enlargement of the distal interphalangeal joints. What is the most likely diagnosis? So let's go ahead with the answer. So this is a history consistent with osteoarthritis. So osteoarthritis is characterized by chronic kind of joint pain and stiffness, morning stiffness. It's worse with activity and it's relieved by rest. And you often get kind of the bony enlargement in kind of later stages, and they're called Heberden's nodes in kind of the joints that we talked about. And it often does affect the weight-bearing joints because it's a wear and tear kind of disease. So the knees and the hips is where you do commonly see it. So in contrast, rheumatoid arthritis usually presents with kind of different symptoms to osteoarthritis, but they can be a bit similar. So usually symmetrical joint involvement, morning stiffness that it lasts for more than 30 minutes, involvements of the smaller joints, so not necessarily the knees and the hips. It can also come along with some systemic features, so other things that are linked in with rheumatoid arthritis is it's an autoimmune disease, and given that it's autoimmune as well, then if you test their bloods as well, they can be positive for rheumatoid factor and anti-CCP as well. Cool, so moving on to the third question. A 30-year-old male presents after a road traffic accident. His right leg is shortened and externally rotated. An X-ray shows a displaced femoral shaft fracture. What is the most appropriate immediate management? Cool, so let's go ahead with the answer. So in this case, the most appropriate immediate management is urgent reduction and splinting. So this guy has turned up to the emergency department with a femoral shaft fracture. So in this case, we're worried particularly about major blood loss in the long bones and the soft tissue damage that's going on there as well. So it's an emergency and it needs to be urgently reduced by orthopedics before taking them to theatre for surgical fixation. So if you're an F1 or an F2 in the emergency department, your priority would be giving them pain relief, first of all, but also at the same time calling the orthopedic team so that they can stabilize the fracture to prevent further injury like neurovascular compromise, bleeding leading to shock and things like that. And then from there, the team will most likely take people to theatre for a surgical fixation for a more kind of long-term management. Okay. Question 4. An 82-year-old woman falls from standing height and sustains a fractured neck of femur. She has a history of multiple similar fractures. A DEXA scan shows a T-score of -2.9. What is the most likely underlying cause of her fracture? Fine, so the answer is osteoporosis. So this is a classic example of what we call a silver trauma. So not necessarily something you would expect to cause a fractured neck of femur, but people of this age and with multiple fractures before as well usually do get full body CT scans after they've had a fall or things like that to assess for major injuries like this one. So this is classic fragility fracture, and it occurs from low impact trauma for somebody with osteoporosis. So her T-score was -2.9, and a T-score of more than -2.5 on a DEXA confirms the diagnosis of osteoporosis. So osteoporosis is common in postmenopausal women and the elderly as well, and it typically affects the vertebrae, the hips, and the wrists as well. Okay, so according to WHO, osteoporosis is defined based on the following bone density levels. So a T-score within 1 standard deviation of a young adult indicates normal bone density. If it's between 1 and 2.5 below the mean, it indicates a low bone mass. And then if it's more than 2.5, it indicates osteoporosis as well. It's worth also mentioning other things can cause fractures. It's not always osteoporosis. So things like having bone mets, having soft bones, which is called osteomalacia, and Paget's disease can also cause pathological fractures, but they usually present a little bit differently. So with things like bone pain, especially with bone mets and things like that, deformities in osteomalacia because your bones are soft, so they bend, and the abnormal lab results as well. So the question here kind of prefaced a great history for osteoporosis in the older lady, with the fracture there, with the T-score that showed that she had osteoporosis as well. Fine. So question 5. A 24-year-old footballer presents with sudden pain and swelling in his right ankle after landing awkwardly during a match. On examination, there is tenderness over the lateral malleolus and minimal bruising. He can weight bear with some discomfort. What is the most appropriate initial management? Fine. So in this case, the management would be rice and simple analgesia. So this is something that you will quite commonly see in the emergency department if you're on a trauma and orthopedic rotation, or if you're on an A&E rotation. So in this case, it sounds like a soft tissue injury, so it's probably something like an ankle sprain. So there is a set of rules called the Ottawa ankle rules that suggest that imaging is unnecessary if the patient can weight bear, so this patient can, and there's no bony tenderness. So he did have a little bit of tenderness over the medial malleolus, but nothing kind of around the rest of the ankle, up the leg, or in the rest of the foot as well. So in this case, the management would be to rest the area, ice the area, put some compression around the area, and make sure to keep the leg elevated as well. And some ibuprofen and paracetamol as well will be the first line. So things like MRI and surgery aren't necessary unless there's suspicion of a severe ligament tear, or if the symptoms don't go away after maybe 6 to 8 weeks. And in this case, because it's not a bony injury, then the guy wouldn't need to be put in plaster or anything like that. Fine, so we'll move on to Sophia now to carry on with the rest of the questions.
Thank you, Catherine. Can you hear me okay? Can you hear me okay? Oh, hello? Okay. So, let's see. My mic is on. Is it not working? Let's see. Okay, let me... Hello, can you hear me? Can you hear me? Hello? Can anyone hear me?
So I think we're just having a few issues with the audio, so just give us 2 seconds. Oh, I think I can hear you now.
Can you hear me okay?
Yeah, we can hear you now.
Oh, perfect. Okay.
There you go.
Thank you. Sorry about that. I'm an absolute like dinosaur when it comes to tech. Anyways. So question 6. Oh, thanks, Catherine, for those 5 questions. So question 6. So we've got an 8-year-old boy who presents to A&E with sudden onset painful right knee. When asked to walk, he cries whenever he tries to take a step. His mother states he fell off his bike 1 week ago, but was able to walk fine immediately after getting up. He has no preceding illness and is otherwise well. On examination, his body temperature is 38.6 and has a slight swelling and tenderness localized over the right knee, and he has some bruises on both sides of his shins as well. So he also has a soft systolic cardiac murmur that has never been documented before. So what's the most likely diagnosis for his condition? So this question is asking you whether you can pick up the sort of red flags in a question. Okie dokes. So the answer here is septic arthritis. So we could pick out some key clues that point towards septic arthritis here. So number 1, he's got a fever and he's got sort of sudden onset painful swollen joint. And whenever you've got a painful swollen joint, you have to think about septic arthritis because this is one of the most sort of insidious, sort of quickest pathologies that you can pick up in A&E and get sorted out quickly. So infective endocarditis, well, just to go back one, just to talk about why it's not the other options. Infective endocarditis, you could be suspecting if they've got a fever and a systolic murmur. But the key thing to note here is that a soft systolic murmur in a healthy young boy is actually pretty normal. It doesn't mean to say that you should completely dismiss systolic murmurs in children whatsoever, but in this particular case, he doesn't quite meet all of the Duke's criteria. So Duke's criteria for infective endocarditis is 2 major, or 1 major, 3 minor, or 5 minor criteria. And the 2 major criteria would have to be bacterial blood cultures. It's at least 2 taken at least 12 hours apart, or cardiac signs of infective endocarditis. So that could be an echo that shows vegetation on a valve. So he doesn't show any of those major criteria. So we would have to fulfill at least 5 minor criteria for it to be infective endocarditis. But if you are thinking infective endocarditis, it's something to sort of keep in mind, and you could always try ruling it out later on and take some blood cultures as well. Acute rheumatic fever, again, there's another set of criteria to learn called the Jones criteria. So the Jones criteria talks about joint pain. The O stands for myocarditis. N stands for nodules that are subcutaneous. E is erythema marginatum, and S is Sydenham's chorea. And then here, in this situation, this boy does not have many of those. He only has the painful joint. So it's very early to say that it's acute rheumatic fever. An inflamed medial meniscus. So you can get an inflamed medial meniscus, but it's a bit uncommon. And the meniscus is sort of in the joint of the knee, and you want to be able to rule out more severe things, such as a septic arthritis in this situation. So it's better to aspirate the joint, rule out septic arthritis, and diagnose inflamed medial meniscus if it is later down the line. In this case, we need antibiotics. And a latent fracture. So latent fractures, they can happen, and the classic example would be a scaphoid fracture, where it doesn't appear on the initial X-ray, but sort of 4 weeks down the line, the patient can develop worsening pain in their hand. So the scaphoid is here. They could get worsening pain in their hand, and they're like, well, my X-ray was fine, like how come I'm getting worse pain? And then they get a further X-ray and it shows avascular necrosis and sort of degeneration of that bone. So latent fractures can happen, and that's why we do repeat X-rays. But in the context of a fever, it's not as relevant in this scenario. Next slide, please. And again. So there's a whole bunch of differentials when you've got a limping child. The key thing to note, especially in an OSCE situation, is to rule out the infections. If it is an infection, then you have to give the antibiotics. Otherwise, they could become very, very unwell very quickly. The rest of them, like SIFI or SUFI, Perthes disease, most of the other ones, like bone tumors, they're more sort of insidious and happen over a long period of time, so the patient won't deteriorate as quickly. The flow diagram on the right gives you a good structure to approach children who are limping. So if you can see on the right, it's a bit small on here, but the slides will be distributed. On the right, it's asking whether it's traumatic, and the left is atraumatic. And if you're thinking it's atraumatic, you're thinking either an infection, bone tumor, or one of those other diseases that we learn about, like SUFI or Perthes disease. So that's a good way to think about it in a sort of structured way. Next slide, please. So key thing on here is you could be asked what's the most common organism. It's Staph aureus. But immunocompromised patients are at a greater risk of more unusual organisms, such as Pseudomonas. They've got that hot, swollen, red joint, inability to weight bear. They'll have systemic signs. And in terms of management, they need that aspiration and that surgical drainage with a long course of antibiotics. In children, you can get transient synovitis as well, which is a differential for septic arthritis. All patients who have that hot swollen joint will get an aspiration, regardless of whether you think it's more likely to be transient synovitis. Next question. Thank you. So we've got a 2-year-old child who's brought to A&E with a swollen leg and bruising. The caregiver reports that the child fell off the sofa while she was in front of the TV. An X-ray shows a metaphyseal fracture of the distal femur. What's the most appropriate next step? Okie dokes. So the answer here is refer to a senior, and we'll talk about why. But if you know metaphyseal fractures, you know it's pretty much pathognomonic for a non-accidental injury. So some clues here, you've got a 2-year-old child, and they've got a plausible history, to be fair. 2-year-old children can roll around and fall off the sofa, but this type of fracture on the corner of the bone suggests that something's going on, that they're at high risk of non-accidental injury and child abuse. So option A would be an option if, for example, someone sprained their ankle, or they've got a simple fracture that can heal over weeks, or they've already had an operation on their knee and they just need to be in a cast for 6 weeks after the operation. Option B, surgical pinning. So it's not really done for metaphyseal fractures, and you can do surgical pinning if it's sort of a bit of bone has come off the end, but not in this case. Ponseti casting, it's used for clubfoot, so it's where they use cast. They put the baby's foot in a literally a cast, and they slowly, over weeks and weeks, try to mold the foot back into alignment. That takes a long time, but it's non-invasive and it's really effective. Option D, gallows traction for 7 days. So gallows traction, it's a really big contraption. It might look quite scary for the child, but basically they're in the bed and there's a big wire that attaches to their foot, and then it goes up, and then there's a weight on the other side, and this traction helps to pull and lengthen the leg, so the fracture can go from like this and overlapping to go back into alignment so that it can heal properly. But in a lot of cases they use gallows traction while the child is still waiting for surgery, and not as the treatment alone. So we're going to refer to a senior in this case because we're suspecting non-accidental injury. Next slide, please. So non-accidental injury is, there are some fractures which immediately make you think it's non-accidental. So as we just talked about, the classic metaphyseal lesions is that corner of the end of the femur, and can be due to pulling, twisting, or shaking. And then you've got posterior rib fractures. They're actually really, really hard to see unless you're actively looking for it on a chest X-ray. So if you're requesting a chest X-ray for a child, it's always important to say if they do have any sort of bruising, and if you are suspecting non-accidental injury. But you can just see here in the arrows where they've had that fracture, and there's also signs of sort of edema or secondary bone healing where they've got that formation around the bone as well. Next slide, please. So you can also get scapular fractures. You'll actually notice that a lot of these fractures that point towards non-accidental injury are part of the central skeleton and rather than the peripheral. So scapular fracture is really hard to get if it's not non-accidental. Spinous process fractures as well, and sternal fractures here can be if someone hits the child on the chest a bit too hard, it can break and cause the child quite a bit of chest pain. Next slide, please. And there's a whole bunch of other potential clues of non-accidental injuries. The pathognomonic fractures are actually a lot less common than what's listed on this slide here. So in practice, you'll probably see a lot more of like different things in the history that are not adding up. If one parent says this happened, another parent says this happened, and that can point towards non-accidental injury. If it's something that doesn't correlate with the child's expected mobility, again, could point towards non-accidental injury. If there's any sort of drug or alcohol use in the household, that's a risk factor. If they've got burns or scalds, cigarette marks, you have to look top to toe. And then once you've identified that it could potentially be a non-accidental injury, refer to senior, and then they'll have a whole discussion with social. Next slide, please. And it actually is quite a long process. The child will need a whole set of bloods and clotting screen to check whether they do have any genetic or like medical conditions that could cause bleeding or bone fractures, and they'll need a full skeletal survey. So that's an x-ray from top to toe. So it's exposing the child to a lot of radiation, but that will be a decision for seniors to make. And another question that could come up is like, would you tell the parents whether you're going to investigate for non-accidental injury? And the general rule of thumb is that you phrase it in such a way that you say, we're going to investigate the medical causes of the bruising, the fracture, but also we have to make sure that someone isn't harming the baby or the child. And you don't always have to necessarily imply that it's the parents themselves. So they just say, we just have to make sure that your child is safe and that no one is sort of harming your baby on purpose. So that's that. Next slide, please. So question 8. A newborn is noted to have asymmetrical thigh skin creases and limited abduction of the left hip during routine examination. The birth was smooth, and which of the following is the most likely diagnosis? Okie dokes. So the answer here, pretty straightforward. You've got DDH. So the asymmetrical thigh skin creases point towards something going on in the hip. And the fact that the birth was smooth points towards the fact that it probably wasn't a breech. And there wasn't anything that, like any trauma, like pulling the baby's leg out of the room or anything like that. So congenital talipes equinovarus, that's clubfoot. And clubfoot doesn't really affect the thigh skin creases, it affects the feet further down. SIFI it's more so diagnosed in sort of 11 to 12-year-olds, like late primary school, early secondary school, particularly in obese children. Perthes disease is characterized by sort of avascular necrosis and pain in the hip, and that's quite unlikely in this newborn baby. And osteogenesis imperfecta is characterized by frequent fractures. They're very fragile, and also interestingly, their sclera is blue. And it actually is blue when you see them. It's not like one of those things in the textbooks where it says, they could have this and it could be like this, but in reality it's quite mild. With osteogenesis imperfecta, they actually do have blue sclera, and it's like sky blue. It's actually quite pretty. But next question, next slide, please. So just an explanation on DDH. So it's more common in female babies, to impress in an OSCE scenario, you would ask about whether there's a history of breech, whether there's a family history of breech, or whether the pregnancy they were told about oligohydramnios, which is a low level of amniotic fluid in the womb. There are two main tests, the Ortolani and the Barlow test. I think of it as Barlow bad. So Barlow tests is where they try to dislocate the hip, and Ortolani is good, where they try to relocate the hip. The main investigation would be ultrasound of the hips. So you only ultrasound the hip if it's a baby or if it's an adult with a soft tissue problem. You can't ultrasound hips in adults because the bone is a bit too solid and the ossification centers have all been formed already. Whereas in a kid, their bones are still squishy, so you can still ultrasound the hips. And interestingly, you can also ultrasound their brain, but you can't ultrasound adult brains because it's been fused together. And then if it's a child who's a bit older, you can consider an X-ray once the ossification around the hip begins. The main management for DDH is a Pavlik harness for, again, a very long time. Or if they're a bit older, then they might need to have an operation. But the main thing is the Pavlik harness. Next slide. So I've got a picture on it on the right. So they just stay like in that harness for about 6 to 12 months, mainly at nighttime. And then on the left, you've got the different tests where they try to relocate and they try to dislocate. Question 9. A 14-year-old boy presents with persistent left knee pain and swelling. The pain has worsened over the last month and is worse at night. And an X-ray shows a mixed lytic and sclerotic lesion in the metaphysis of the distal femur with a sunburst pattern of periosteal reaction. What is the most likely diagnosis? Okie dokes. And the answer here, it's already been highlighted, but it's osteosarcoma. So the key things to note here, so he's got some left knee pain, and it's a bit swollen, and the sunburst pattern really gives it away. And it's also the most common bone tumor in children, or primary bone tumor. Osteoid osteomas, they're benign, and they can cause pain, particularly at nighttime as well, but are mainly managed with NSAIDs, so pain management. Ewing sarcoma can also happen in children, but is characterized by a more onion appearance. So while the osteosarcoma will look like it's coming from within the bone and it bursts out, the Ewing sarcoma will look like it's stuck onto the side of the bone with layers coming off. The chondrosarcoma is a malignant type of bone tumor, and that originates from the cartilage, and that's quite dangerous, quite invasive, but the orthopods will tend to deal with they'll decide whether to cut it out and give a replacement, or whether to keep monitoring it. And osteomyelitis is an infection of the bone, but we don't have any signs of an infection here. Next slide. And next slide again. So, just go back one. So just got some pictures of, the top left is the osteoid osteoma, and on the X-ray, it can look like a bit of a sclerotic lesion. I've got a sclerotic area of bone around it, and the one on the right is an MRI, is an MRI scan, so it won't show the sclerotic bit as more white. And then the picture on the right is the osteosarcoma, so you can see the sunbursting appearance, and it's all flaring out from the burn. And then on the bottom left, it's very faint, but it looks like onion layers. So it's kind of, you've got the normal bone and then you've got the layers on top of it. And then the one on the bottom right is that chondrosarcoma, where it's got a popcorn appearance, and it looks quite plastered to the bone. And next slide. And that just puts it more in a more graphic way. And next slide. So when you've got a patient with a suspected bone tumor, they might not actually present with just bone pain. They might also have features of hypercalcemia as well. So they might have stones, groans, thrones, and psychiatric moans. So pain, constipation, calcium stones. And sometimes they can present with infection-like symptoms as well. So it's important to get that X-ray in the first instance. And once a potential bone tumor is identified, the whole bone needs to be scanned with an MRI. And then they'll potentially go for a bone scan and a biopsy. But in the acute setting, they're more likely to present with hypercalcemic symptoms. So you do your A to E, fluid resus. A lot of fluid is needed for hypercalcemia. Give analgesia, consider bisphosphonates, and refer to ortho. And then ortho will take it from there. And they've got some really cool surgeries and replacements that they can do for bone tumors. Next slide, please. In an OSCE situation, when you're presented with an X-ray and you see some kind of bone tumor, it helps just to know what the simple descriptive terms are, so you can really show off to the examiner. So lytic means removal of bone. On the X-ray, it will look darker than usual. Sclerotic means deposits of bone, so it looks whiter than usual. Expansile would be like, it looks like it comes from within the bone and it goes beyond the normal bone contours. So like in that sunburst picture that we saw before. Invasive means it goes into the surrounding tissues. Well circumscribed means you can see a very clear outline around it. Diffuse means you can't see that clear outline. And multiloculated, so you've got those. It looks, again, a little bit like popcorn. Next slide, please. Last question. So a 68-year-old man presents with worsening pain in his right foot. The pain has been getting worse over the past 2 days, and he now feels generally unwell with a fever. He was admitted 2 weeks ago with an infected arterial ulcer on the base of his right heel, and he has a history of type 2 diabetes. The ulcer is now very deep, and there is exposure of bone. What investigation is required for a definitive diagnosis? Okay, dokes. And the answer here is actually a bone biopsy. So this one is a little bit tricky. It's asking you which of these investigations would give a definitive diagnosis. And in reality, you do all of these investigations, but we'll go through them. So the most likely diagnosis here is osteomyelitis. He's got a fever. Oh, sorry, previous question. Previous slide, please. He's got a fever, he's got exposed bone, and he's got risk factors such as type 2 diabetes, and he's got that infected arterial ulcer as well, so we've got a source of that infection. X-ray foot, you'll be able to see potential changes, but it won't be sort of definitive. MRI foot, you can treat for osteomyelitis due to radiological changes on an MRI, but it won't give you a definitive diagnosis. So the radiographer will say there's osteomyelitic changes, and then you can start treating the osteomyelitis, but it's not a definitive diagnosis because you don't know exactly what bug is growing. Blood cultures can help give you an idea whether it's septic, and a bone biopsy is really needed. So what they do is they take a clean bone sample and a dirty bone sample. So when they're presented with the infected bone, they try to cut away at that infected bone until there's just clean bone left. And then they take a sample of that clean bone that's left on the patient and a sample of that dirty bone that they've just chipped away, send it to the lab. And if the dirty bone has all these bugs growing, then you can diagnose that osteomyelitis. But also, if the clean bone shows there's no bugs growing, that means you can be reassured that they've taken out all of the infected areas. And obviously, if the clean bone shows bugs growing, then they need to go back and debride a bit more. So your next slide. Yep, so bone biopsy is the gold standard. And brief overview of osteomyelitis. So it's usually caused by Staph aureus, but in sickle cell patients, you can get it from Salmonella. And actually, a rising cause of osteomyelitis in children is Kingella kingae, which has become a lot more common in recent years. So they present with bone pain, swelling, warmth. It can look very similar to septic arthritis. You do bloods, cultures, X-ray, MRI, and a bone biopsy if possible. And they need a long course of antibiotics as well, minimum 2 weeks of IV, and then oral antibiotics for 4 weeks after that. So a total of 6 weeks of antibiotics. And sometimes, if it's really, really severe, they might go home on IV antibiotics as well. And surgical debridement is the main way we get rid of osteomyelitis. So that's all of our questions. Thank you very much for listening to this presentation. Our next session is next Thursday, which you can sign up for using our Linktree or on Medall. And we've also got some sessions happening on Saturday mornings as well. So we've just started our Morning in Wherever series. So we started off with Morning in a GP, and we saw quite a lot of you there, and it was really fun. It was a whole morning of most common presentations, really casual, just getting all of those basic presentations hammered into our brains. And then the upcoming sessions will be Morning in Surgical Unit and a Morning in the Medical Unit as well. So we hope you found it useful. I'm not sure if Catherine wants to add anything.
No, I think that's all good. I just will hang around if there's any questions or anything like that. But obviously, if you guys watch the recording and have any questions, just feel free to DM us, and we're happy to have a chat with you over Instagram as well. So I'll just stop sharing my screen, and then we'll hang around for a little bit just in case there's any questions.
This feedback form should be in the chat. But yeah, thanks for joining us, everyone, even when the weather is so nice outside. The videos and slides for Day in the GP and General Surgery will be released. They'll be released quite soon. So the Day in the GP one is the most recent one. They'll be up quite soon, but you should get an email when they do go up.
So if that's everybody kind of wanted to get out in the sun and there's no further questions, then I think we'll leave it there. If you guys could leave us some feedback, that'd be really, really helpful. It's always really helpful, and it's helpful for you guys in the future as well. So it shouldn't take too long, but we'll leave it there. Cool. Have a nice evening, guys.